Um, Good afternoon, all our postgraduates. I guess not just the postgraduates, we are looking forward for attendance from our medicine faculties also. I can see most of you are glued to the questions. I think Dr. Ramya has given very tough questions. So, but anyway, let me just take this time. So let me just give a little background of what this whole thing is going to be. Where is Sheba? So I just want to thank our PG committee, Dr. Sheba and all of them who have been working hard to make this postgraduate lectures. So what we would be planning to do in this session is, as much as we will be having the lectures by the faculties, we don't want it to be passive, and so we want more interactions from each one of you. So our faculties will be coming prepared with some pre-tests and posters to see how you did and how the lecture has changed your impression about it. Hopefully we'll make it a little bit more complex, and we don't want any of you to come, sit, and listen to what is being taught. We would want you to read on that subject and come and sit. And slowly, these didactic lectures will change into interactive sessions where we will be primarily asking you questions and giving you situations and see whether you are able to approach it and answer it. So hopefully that transition will happen. So few things from the Department of Medicines we want to make it. Number one is these are mandatory sessions for all postgraduates. So I am expecting 100% attendance. Those who have not come today, please inform them that they need to be here. There's no exceptions to that. All these are being recorded, monitored. All your MCQ scores will be captured, and that will be against your name. So lecture attended, that is your attendance there or not, your score that you got for that lecture, and those scores will be watching those scores over a period of time. Is your scores improving over a period of time, right? So number one is that lecture will be 100%, everybody has to attend it. Number two is that your involvement in these lectures will decide how you'll be moving up your course in your postgraduate training. So make sure that today's first day. I think all of you will be getting used to it, but subsequently we would want 100% attendance and your involvement in these whole lectures. Want to thank the PG committee once again for organizing this. There'll be many more things that will slowly add on to these sessions that we are looking forward for. Let me take this time to welcome Dr. Ramya Rajan from the Department of Endocrinology. She is the associate professor, and she is dealing with pituitary, adrenal, gonad, and type 1 diabetes. She has finished her DM from here. She has done her MD medicine from Lady Harding, and she has done her graduation from Kilpock Medical College. Her very friendly neighbor has told that whenever she goes there, sees her sitting in a bulk of books, very studious is the impression that people get about her. And so we are looking forward for a feast of knowledge that will be coming from here. So over to you, Dr. Ramya. The time is yours.
Thank you, sir, for the kind words of introduction, and also thank you, Medicine Department, for the invite. So today I will be dealing with approach to pubertal disorder. The major part of the lecture will be on delayed puberty and hirsutism, with a few case examples on disorder of sexual differentiation. So this will be the outline of the talk. So before going into pubertal disorders, let's have a look at what is puberty and what does it mean. So we all know that the pituitary gland is the master gland, and the stimulus for most of the endocrine organs come from the pituitary. And similarly, the gonadotropins are secreted from the pituitary. So stimulus for the gonadotropin secretion, that is by gonadotropins we mean LH and FSH, it comes from the hypothalamus, which has the GnRH, which secretes GnRH. There is a GnRH pulse regulator. So it produces GnRH, which acts on the anterior pituitary, produces LH and FSH, and these act on the target organs, that is in males on the testes and in females on the ovary, resulting in production of sex steroids. So what happens is that during the period of childhood, this GnRH axis, that is, this is called HPG axis, hypothalamic pituitary gonadal axis. This remains quiescent and there is no GnRH secretion from the hypothalamus. Even if it is there, it is a minimal secretion, just a flat line. So what happens with the onset of puberty is that this GnRH pulse regulator, it gets activated and it results in a pulsatile secretion of GnRH from the hypothalamus, which result in further secretion of LH and FSH. And this is the negative feedback which controls the HPG axis. So there is GnRH from the hypothalamus, which acts on the anterior pituitary, resulting in secretion of LH and FSH. This further acts on the testes and the ovary, resulting in production of sex steroids. And there is always a negative feedback loop which acts and thus maintains the homeostasis. So it's very important to know when we deal with puberty, we should know what happens actually during puberty. Only then we'll be able to find out what hasn't happened with the patient, what hasn't happened in the patient's life when they come with a problem with puberty. So what we are commonly aware of is the changes which occurs in genital organs. That is, there is breast enlargement in females, there is pubic hair development which occurs in both males and females, and there is testicular enlargement which occurs in males. In addition to this, something which strikes is that very important is the growth spurt which occurs when a person enters puberty. And in males, there is deepening of voice, their voice thickens actually. And also males, there is an increase in muscle mass. On the other hand, in females, there is increase in fat mass which occurs. And also they undergo a variety, there is an array of emotional changes which also occurs in this adolescent age group. So now coming to delayed puberty, first we should know what is delayed puberty before we go into delayed puberty. So when we define delayed puberty as absence of signs of puberty. So by means signs of puberty, we mean in a female absence of breast development. That is the first sign of puberty which we expect in a female, and in a male, the testicular enlargement is the first sign of puberty which we expect. So when there is no signs of puberty by 13 years in a girl and 14 years in a boy, that is how delayed puberty is defined. And also, if someone is not, irrespective of the other development of secondary sexual characters, if a girl is not attaining menarche by 15 years, even then it's called delayed puberty. And also for sometimes what happens is the puberty starts, however, over the period of next 5 years, it won't progress further. So if someone starts having breast development, however, is not attaining menarche over the next 5 years, again, that is called delayed puberty. So when we talk about delayed puberty or any pubertal disorder, it is very important for you people to get used to this Tanner staging, by which we grade the breast development and the pubic hair development in a female and pubic hair development in a male. You can always Google it. This was proposed by Tanner and Marshall based on the study which they done in the 1930s and 40s. So you can go back and look at it. It's quite simple actually, but however, you will get used to it, the differences in the Tanner staging only when you do it yourself in the OPD. Okay. So the breast development, it starts with B1. P1 is basically pre-pubertal. That means that is before the onset of puberty. So once the puberty starts, initial what happens in the breast is that the breastbed appears, and from stage 3 onwards, the glandular tissue in the breast starts coming up. Something to remember, it is not just the glandular tissue, also the areola also develops, so it becomes bigger. And by stage 5, it reaches the adult breast development. Similarly, in the pubic stage 1 is there is no hair, or sometimes there may be few vellus hair. Then by stage 1, they start having this thick hairs, few hairs, and as progresses, it increases in size. And in a female pattern, it will be an inverted triangle pattern. That is the adult female shape. So even this gets altered. Sometimes what happens is when there is increased androgenization, this inverted pubic triangle, that is inverted triangle, can become like a diamond shaped distribution of pubic hair, which is a sign of androgenization in females. So when we come to the Tanner staging in males, similarly in P1 there is nil or almost no hair. Then it starts and it further progressing. And in P5, along with this distribution of hair, males are also supposed to have thighs, hair over their thighs, which classifies them as grade 5. So this shows what does the people present with. This is what? So this picture shows how they present to us at various stages of development. As I told earlier, during the as I told before, during the childhood period, that is initially when they are born, they have a small period called mini puberty, which occurs in the first 6 months of their life. That is, it starts by 2 weeks and usually comes down by 6 weeks. And then from about after the infancy till the onset of puberty, maybe by about 11 years or 12 years, this HPG axis becomes quiescent. And so usually, unless they have any other clinical signs which are associated with hypogonadism, usually during this time it's very difficult to pick them up and mostly they won't come to clinical attention. It is after the activation of, after once the puberty sets in, that is when they come to clinical attention. And most often in the adolescent age and in the early, maybe late 20s, they come to, in the second decade, they come to clinical attention with the complaints of absence of puberty or delayed puberty. And once they go into adult life, they come to clinical attention mostly because of decreased libido or infertility. So we'll go into two case scenarios here. We'll side by side, we'll have both because one is female and the other is male. So this is a 20-year-old lady who has presented with complaints of delayed puberty and short stature. So this is an 18-year-old boy who has presented with complaints of absent secondary sexual characters. So when we see a patient with a certain complaint, first we should know in our mind, what am I looking for? What may be the possible etiologies for the same? Only then you will be able to elicit a proper history. So first, let's look at what are the causes of delayed puberty so that you can ask relevant questions. So delayed puberty, when we look at the causes, it can be broadly classified into two categories, that is hypergonadotropic hypergonadism and hypogonadotropic hypogonadism. By hypo, what we mean that the problem is basically in the primary organ, that is either in the testis or in the ovary, and hence they have elevated, because of the loss of negative feedback, they have elevated gonadotropins. So when we say hypo, the basic problem is either in the hypothalamus or in the pituitary. So there are certain features. So those which are marked in pink are those which occurs in females. Those which are marked in blue are those which occurs only in males, and those which are in black can occur in both females and males. Okay. So when we look at the anatomical defects, these occur solely in females, and usually how they come to clinical attention is they come to clinical attention saying that I haven't attained menarche. But usually when we examine them, they will have the features of other features of puberty, like there will be breast development, there will be adequate pubic hair development. However, the only complaint will be absence of menses. So that is because of the problems, either Mullerian agenesis means absence of uterus, or there is some problem with the vagina or imperforate hymen. So these are some anatomical defects which occur solely in females. So when we look at hypo, so the most common one in female is the Turner syndrome, and the most common one in male is the Klinefelter syndrome. And also, we should think of acquired causes which can cause this because of radiotherapy to the pelvis or chemotherapy. They can develop premature ovarian failure as well as premature testicular failure. And hypo. So, most important thing generally when we deal with adolescents, one of the most common thing which you have to keep in mind is constitutional delay in puberty. But once the person is more than 18 years, this goes away from the differential diagnosis. And the other thing is isolated hypo, which can occur in disorders related to pituitary or hypothalamus. Either it can be a pituitary tumor, it can be radiotherapy, it can be a surgery, a head trauma or a surgery, and also it can occur as a congenital form, that is some congenital deficit because of transcription factors. I'm not going into details of each of this, but it can be because of either because of pituitary disorders or because of any problem with the hypothalamus. And also please remember that even systemic illness which go untreated for a long time can also cause hypothalamic amenorrhea, and hence they can present with delayed puberty. And there are certain drugs, especially if they're abusing some drugs like anabolic steroids and all, they also can cause delayed puberty. So when we elicit history, as we all know, whenever we elicit history for a disorder, first we elicit history relevant to the presenting complaints. Then we ask history to establish the etiology of the disease. And then we go on to ask history with respect to complications of the disease, which we are looking for. And sometimes here we have to ask history related to some associated features which can point out to the etiology. So when they come with pubertal disorder, is we have to ask about all the pubertal changes which can occur in a person. That is, if it is a female, is there is again the colors is pertaining same, like if it is pink, it occurs only in females. If it is blue, it occurs only in male, and all the other things for both the sexes, both the genders. Okay. So in female, we have to ask about history of whether there is breast development, have they noticed breast development. And hot flushes is something when they complain, when they have hypo, especially if they have a recent onset, like if they have undergone chemotherapy and they have developed premature ovarian failure because of that, they may even complain of hot flushes. Usually it doesn't occur with a pituitary or a hypothalamic problem. And in males, we have to ask about the feminine voice. There is no change in voice, absence of facial hair, gynecomastia, whether because in puberty, as they enter into puberty, they start having erections and they may even have ejaculate. So they can ask about that, whether they are having erections in the morning hours. And in the both the genders, we have to ask about absence of pubic hair. And this is something because growth spurt occurs if there is no puberty, the growth spurt may be delayed. And the other thing, when they remain hypogonadal for a long time, remember like estrogen in both males and females have testosterone and estrogen. For a male, estradiol is required for the fusion of epiphyses. So in the hypogonadal male, because there is no estradiol, what happens is this epiphyseal fusion won't happen, and so they keep growing for a long time. So sometimes what happens is, initially to start with, during their adolescent time, they may remain little short when compared to their peers, but over a period of time they overgrow everyone, and by 20 years of age, when they come to you, they tell that he's the tallest member of the family. So that is a common history which we get. This is because of the absence of estradiol leading to absence of epiphyseal fusion, so they continue to grow. And then history related to the etiology. So something, this history of delayed puberty in family, that is when someone presents with history delayed puberty less than 18 years. I told constitutional delay in puberty can be a differential diagnosis that can coexist in family. So we ask history of delayed puberty, delayed shaving frequency, or delayed menarche in mother and father. And then birth history is important because what happens is, in case of multiple pituitary hormone deficiency, which can occur, which is an important cause of hypo. So because of the other hormone deficit which can coexist, like cortisol deficiency at birth, these children can present with seizures because of hypoglycemia. There can be delayed, they can have persistent physiological jaundice. These things can occur. That is why birth history is important. And also it has been seen that growth hormone and this pituitary hormone deficits coexist. There is an association between breech delivery. So that is why birth history becomes important. And then short stature, especially in females. When we tell short stature, someone comes with delayed puberty, short stature, first thing which should strike is Turner syndrome. And history of intracranial mass, head surgery, chemotherapy, radiotherapy. These are all occurred causes of delayed puberty. So associated history, so a history of ear infection in a girl who is short and has delayed puberty again points towards Turner syndrome. And cardiac anomalies also points towards Turner syndrome. And history of hyposmia and anosmia can occur in hypo because these neurons, they develop at the same place and then they migrate the olfactory neurons and this. So that is the reason they can have hyposmia as well as or anosmia. And urogenital malformations can occur in Turner syndrome as well as in Klinefelter syndrome, which is the most common chromosomal DSTs which we look at. And skeletal defects also can occur in both Klinefelter and Turner syndrome. And varicose vein is something which can be associated with future of again Klinefelter syndrome. So now coming to the case history first, you remember case 1 was a female who presented at 20 years of age with history of short stature and delayed puberty. So she noticed that there was absent breast and pubic hair development by 17 years, and also earlier age itself, she has noticed that she has been shorter than her peers and her siblings. And also history related to the etiology, she has short stature. However, there is no history of delayed puberty in the family. No associated history should. There was an associated, sorry, we missed on it. There was history of ear infection which the patient had. So coming to the case 2, so this boy who came with absent delayed secondary sexual characters at 18 years of age, so he noticed that there is no, even when he has become 18, that is because he is concerned because his peers are having hair, he didn't have facial hair. Also by 15 years, he started developing gynecomastia. Remember, gynecomastia can occur in 30% of the children during puberty. And among this 30%, about 70% resolve once they complete their puberty. For some children, they can even persist beyond that. So remember, gynecomastia is not always pathological. It can be pubertal as well. He developed gynecomastia by 15 years of age. And also, though he started having his puberty, that is, his voice started deepening, it didn't progress further. It just started, he had some breaking of voice and all, but further testicular enlargement and that pubic hair distribution, which we expect in an adult person, didn't happen for him. And history, he was normal stature, he didn't have short stature, and he didn't have any further associated history. There was no hyposmia or anosmia in him. So now going to examination. So first, when we examine a person with delayed puberty, so we have to first confirm that the patient really has delayed puberty. So height is always like, this is routinely checked for all our patients. So, but this is very important. Height is very important because by this that will give us an idea whether this patient has a normal stature or he has a short stature or they have a tall stature. And we compare their height with the mid-parental. MPH is mid-parental height. I'm not going into the details of that because I don't think that's necessary, but usually we have a formula to calculate the mid-parental height using the father's height and the mother's height, and we can compare because once they come by 18 years of age, we expect them to be adult, and their height should fall in the target range of their parental height. So if they are not falling in that range, we consider that to be short stature, even though they are not short in the growth chart which we look at. So an upper segment, lower segment ratio and arm span is very important, especially in a male who comes with delayed puberty. So we all know, you'd have all studied about body proportions in pediatrics, that by 9 years of age, that the proportions become equal, and after 9 it comes down to a normal value of 0.9. If someone has an upper segment lower segment ratio which is less than 0.85, they are considered to be unicoid. That means their trunk is shorter than the limbs. So that, because this is important, because for the normal development of the normal growth of the tongue, the gonadal steroids are very important. So when there is deficiency of gonadal steroids, this normal growth of the trunk won't happen, and hence the limbs outgrow the trunk. That is why they develop unicoid body proportions. And again, Arm span, when it is up to 5 centimeter more than the height, it is considered to be normal. But when it is more than 5 centimeter more than the height, that is considered to be abnormal. That means that the limbs are longer than the trunk. And very important, we should look at this Tanner staging, in which we will look at the breast for both males and females. You should look at breast for men as well, because they can have gynecomastia, which could be a symptom of hypogonadism, pubic hair, and whether they have developed axillary hair. And we should look at the testicular volume using an orchidometer. That it has beads, and you can compare the size of the beads with the testis, and we can notify how much is the testicular volume. And then we should look up, once we have established that yes, they have delayed puberty on examination as well, we should look at etiological association. So these are some features which can occur in Turner syndrome. I will show you a picture of Maitland deformity. They can have Maitland deformity which occurs in the hands, which is a skeletal deformity. They can have short neck, they have webbing of neck and wide carrying ankle. And this hyposmia and synkinesis. Synkinesis means mirror movements. When we ask them to move the hand on one part of the body, one side of the body, the opposite side also starts moving. So this can occur in hypogonadotropic hypogonadism, especially Kalman syndrome. So this is wide carrying angle. This is a patient with Turner. So by wide carrying angle, we mean the angle formed between this line and this line. So ideally, it should be measured with a goniometer. However, in clinical, in a bedside, we can measure it using two scales. So this is, I didn't have a clinical picture of webbing of neck, so I took it from the net. This is how webbing of neck occurs, and this occurs in about 20 to 30% of patients with Turner syndrome. This is an orchidometer which we use for checking the testicular volume. So this is how a Maitland deformity looks clinically. So there is deformity. It is because of the poorly development of the radial head, actually, because of the ulnar part of the distal end will subluxate. That will look like this. This is not very specific for Turner syndrome, but however, when we have a short female and who has delayed puberty, yes, this adds more value. So this is the case one. We remember a 20-year-old lady who presented with complaints of delayed puberty and short stature. Definitely she is short, and her height is only 128 centimeter. She is way shorter than her parents. Her mid-parental height is 155 centimeter. She is at least 25 centimeters shorter than them. And her Tanner staging is pre-pubertal. She is B1, P1. So she had wide carrying angle. She had a shield-like chest. Shield-like chest is like widely spaced nipples when we look at the chest. And also she had Maitland deformity. So this is the case 2. That is a 18-year-old boy who came with complaints of delayed puberty. So he was into the taller side, something more. This is the higher. He's on the higher centiles actually. So he's 186 centimeter. Yes, definitely when compared to his mid-parental height, he's tall actually for them. And he had a unicoid body proportions. The upper segment, lower segment ratio was 0.8, and his arm span was higher than at more than 5 centimeter higher than his height. And he had some pubertal development. He has developed his testicle, but something which was very striking was this. His testicular volume, though he was P4 and his stretch penile and this 8 centimeter, his testicular volume is only 3 ml. That means he has started puberty, however, he haven't progressed. History-wise also, he had the same thing. He had deepening of voice, but further development didn't occur. Okay, so he didn't have anosmia, he didn't have synkinesis. So now going to how will we investigate a patient who has delayed puberty? The first, if they are less than 18 years, there's definitely bone age helps, because that also gives us a clue towards if their bone age is also delayed and they are short as well, that may give a clue that this patient may have a constitutional delay in growth as well as in puberty. Okay. And the next thing which we look at is LH and FSH. Estradiol and testosterone always need not be done. But when a male comes, we order LH, FSH, testosterone, and a female comes, we order LH, FSH, and estradiol. So because this itself will give us a clue whether it is hyper-hypo or hypo-hypo, and further we can take it forward. So karyotyping is not always required. When it is a hypergonadotropic hypogonadism, as karyotype has to be done, because Turner and Klinefelter again are the differentials, and these are chromosomal disorders. And karyotype again is necessary if there is any ambiguity. either not only phenotypically, but also if we are like someone is coming as a female, reared as a female, you do an ultrasound, you don't find a uterus at all. Yes, that is ambiguity again, inside gonadal ambiguity. So whenever someone presents with ambiguity, we have to do a karyotype. Usually hypogonadotropic hypogonadism doesn't need a karyotype. Okay? And USG pelvis to look for the Mullerian structures and also for figuring out urogenital anomalies which are common in chromosomal DSTs. And if the investigations reveal that there is a hypogonadotropic hypogonadism, we have to proceed with an MRI pituitary. And if it is hypo, other hormone, pituitary hormone axis also has to be done to rule out other coexisting hormone deficits. Inhibin B and GnRH stimulation test are someone which we do when there is a confusion between CDGP and hypogonadotropic hypogonadism. I'm not going into details of that. So coming to the first case, a 20-year-old girl, absent secondary sexual character. She had ear infection. She was short. She was pre-pubertal and she had features of Turner syndrome. As expected, here actually the diagnosis of Turner syndrome most often is made clinically itself. Most often we'll be able to make it. And sometimes when they are mosaic, they have very borderline features. So LHFSH both were elevated, suggesting hypergonadotropic hypogonadism. The karyotype was suggestive of a isochromosome, which is one of the chromosomal. The most common anomaly is XO, which is 45XO, absence of X chromosome, but these are the other structural defects in the X chromosome which occurs. And UST revealed an infantile uterus and ovaries were not visualized. So this is the X-ray of that Maitland deformity. Here, this portion, this ulnar portion of the radius is not developed, well developed, and hence there is subluxation of the head of the ulna. Now coming to the second case, that is he had absent secondary sexual characters and gynecomastia. He was tall, he had unicoid body proportions, he had some pubertal changes, however the testicular volume was low. And something here, it was firm as well, the testis. Okay. So the investigations again revealed that he had a hypergonadotropic hypogonadism and the testosterone was low. So the karyotype confirmed the diagnosis of Klinefelter syndrome. So a word about constitutional delay in growth and puberty. So this can be a physiological thing, more common in boys actually. So along with the delay in puberty, there is also delay in the height as well as bone age. And more often they will have a family history which is associated. There may be some parent, there may be either of the parent who had a delayed puberty, but very difficult to ask that question. How we ask is like, at what age did you shave? They may remember that they shaved only when they went to college or like after college only they shave. So and in women they may remember because it is the menarche which we ask, at what age did you start having your cycles? Okay, so usually when they are born they are normal. By around 2-3 years they decelerate, they come down, and after that actually what happens is usually when they are born they are absolutely normal. At about 2 years they decelerate little bit and then they continue to grow at the same pace. But what happens is they ultimately attain the adulthood, but it will be little later. Okay. Maybe when the pubertal changes, if it happens around 12 years in a normal person, they will start puberty only by around 14 years or 15 years. So now coming to case 3. So this is an 18-year-old male who presented with short stature. He was breech and he had no systemic illness. This is how he looked. So what is most striking? So this is an 18-year-old boy. Yeah, he's very short. That is, and look at his face. He looks like a child, right? He doesn't look like maybe he looks like a 6-year or 8-year-old child. And gynecomastia. It may be gynecomastia or lipomastia. Unless we examine, we won't be able to tell what it is actually. So it was actually lipomastia. So on examination, he was short. He was only 124 centimeter. His mid-parental height was 166. He had child-like faces and tanner. He was pre-pubertal. He was P1. However, his testicular volume, puberty has started maybe like because that has become 5 ml. Then the stretch penile length was also 2 centimeter. So investigations revealed that his LH, FSH were low actually. When we have a testosterone of 29, for hypo, we expect LHFSH to be high. Here it is low. And in fact, he had multiple pituitary hormone deficiency. He had low gonadal hormones. He had low IGF-1. His T4, free T4 was low, and even his cortisol, we did a synactin, he didn't rise above 18. Okay, so he had multiple pituitary hormone deficiency, and this is his MRA. We can make out that there is a very thin strip of pituitary tissue left there. So he almost have a empty kind of thing. And also, can you make out this? This is actually a ectopic posterior pituitary which is sitting there. Okay. And the stalk is not clearly seen. This is kind of pituitary stalk interrupted syndrome. So when we look at the treatment, how do we treat this? So when females, when they come with delayed puberty, yes, we treat with estradiol. We initially start with, usually remember in any person, puberty happens over a period of 2 to 3 years, and it's a very gradual process. And when we treat as well exogenously, we try to mimic the same. We are not in a hurry to start OCPs and finish off. We start very slowly. In fact, we start with 0.25 milligram of estradiol. We gradually build up. We reach the maximum adult dose by 2 years, and after 2 years we add cyclically progesterone. And very most important thing here is, when you before adding progesterone, uterine size has to be checked, because once they become adult, though they don't have the ability to mother a child or like have a baby, nowadays donor ovum, IVF, all these things are coming up. And so if they want to have that option of having a baby, their uterus should be big enough to hold a baby, to support a baby. So that is very important, measuring a uterine size before starting them on progesterone. And in males, we can induce puberty either with testosterone or with gonadotropins. Both will do the same job. Only difference is, when you use gonadotropins, we also induce spermatogenesis. But when we use testosterone, spermatogenesis is not possible. So fertility is not an option. So first, when they come, we can give the option of inducing puberty with both testosterone and gonadotropins. Gonadotropins is really painful because, one, the cost of the treatment, monthly cost will be around 15 to 16,000, and also they will end up taking 3 to 5 injections per week, subcute injections. But what we can tell them is, once we induce with gonadotropins and their testosterone levels are normal and they have some sperms in the semen, we can freeze them. There is an option of freezing it and then going back to testosterone, so that in future, when if they want to have a baby, we can use the sperm which have been frozen. But some people may not prefer that. So option is going to testosterone. Once they are planning the pregnancy, like when they are planning marriage, we can start them on gonadotropins, and then we can, once they father a child, we can go back to testosterone. Testosterone preparations are available once monthly, as well as once in 3 months preparations. Long acting preparations are also available. So now coming shortly to approach. So this is most often gone because adolescent children won't come to you. So first we will look at the LH-FSH. And if the LH and FSH is high, then it is primary hypogonadism. We have to look at the karyotype. So karyotype will tell us, most often they end up being Klinefelter or Turner. So if the karyotype is normal, there is an entity called premature ovarian failure, which can occur because of some transcription factors which are essential for the development of ovary. That also can occur actually. And then if the LH-FSH is low, and then that is suggestive of central hypogonadism, and hence we have to do an MRA and other pituitary hormones. And in both, the treatment remains the same. Induction of puberty remains the same. So a person who is hypo can father or mother their own baby, because once we give the gonadotropins, it's like physiological. Their ovary and testes are intact actually. But a person who is having hypergonadotropic hypergonadism cannot have their own baby. They have to opt for other thing like donation. Okay. So coming to hirsutism and oligomenorrhea. So first, before going into oligomenorrhea or PCOS, you should know certain definitions. What does a normal menses mean? A normal menses means the length is usually 21 to 35 days, and they have a bleeding of about 2 to 7 days, and usually they are predictable. When someone has a predictable menses, when someone says that I will have periods once in 30 days, 32 days, 28 days, that means that the menses is predictable and hence it is ovulatory. So we should suspect an ovulatory cycle when the cycle lengths are either more or it is less, or if there is a variability between. So this month they had after 28 days, next month they had after 40 days. When such things occur, it means that the menstrual cycles are anovulatory. And also, when we say polymenorrhea, that means they are having cycles at an interval of less than 21 days. And when they say oligomenorrhea, they mean that the menstrual cycle's length is more than 35 days. And also, when someone comes with a history of telling I have irregular cycles, and if you ask that, are you having at least 9 cycles a year? That means that's okay. That reassures that there is nothing major actually. So amenorrhea means absence of menses for at least for 3 months, and menorrhagia and hypermenorrhea means they are having increased bleeding, and hypomenorrhea means they are having decreased flow. That is, the flow lasts for less than 2 days. It's a very common complaint that patient says that I have regular menstrual cycles, but my flow is not adequate. Previously, I had it for 3 days, 4 days, 5 days. Now I am having it for only for 2 days. But actually, in them also, you can reassure them. It is seen that as the age progresses, actually the duration of the cycle decreases, and also when they become obese, gain weight, also the duration of cycle may decrease. So this is something like Tanner in delayed puberty. This is something which you have to get used to when we quantify hirsutism in a female. So this is called modified Ferryman-Galloway score, which includes nine sites. The best way of doing it is you yourself examining the sites and notifying. Some people also do that. They show the pictures to the, because most often nowadays what happens when the patient comes to the OPD, they remove the hair and come. So we won't be able to assess the real score actually. So one way of doing it is asking the patient to quantify, but that always overestimates. What I have seen is almost always it's overestimates. So the what is the cutoff we use for hirsutism usually varies from ethnicity to ethnicity. As we all know that in certain ethnicity, it is female may have some amount of hair in the hands, leg regions and all, but in certain ethnicities like Chinese and all, they don't have almost no hair. So in them, even a FG score of 3 becomes significant. But usually in Indian setting, a FG score of more than 8 is considered to be hirsutism. But remember, even if the score is 8, if a person is concerned about, if a patient herself is concerned about hirsutism, yes, that needs to be evaluated and that needs to be treated. So like looking at the hair cycle, usually hair consists of 3 cycles: anagen, catagen, and telogen. Anagen is the growth phase when the hair grows. Catagen is the phase in which it goes into a senescence, and during the telogen phase, the hair will shed off. This hair cycle will vary depending upon the different areas, and for a facial hair more commonly it is about 6 months. So this is important because when we treat someone for hirsutism, you should explain to the patient that you should patiently wait for at least 6 to 9 months for the effect of whatever treatment is used to reflect in your body, because that is the length of the normal hair cycle. And also, when they come with hirsutism, you should first know which hair is pathological. It is not that all hairs are pathological. Whatever hair we are having in our forearms, they are actually vellus. So they are fine, soft, and they are non-pigmented. And if a woman has such hair in her face, actually what you have to do is reassure them. So that's actually vellus hair. What we are concerned about is this thick, long, and pigmented hair, which are called terminal hairs. So this is what we are concerned, and not this vellus hair. The increased presence of vellus hair is actually called hypertrichosis. It's not called hirsutism. So what is hirsutism? It is defined as excessive hair growth, that is excessive terminal hair growth in the androgen dependent areas in a male pattern. So what are the androgen dependent areas? They are the upper lip, that is the mustache area, the beard area, the pubic area, the thigh region. These are the areas of androgen dependent areas. And when someone has increased excessive hair, when a woman has excessive hair growth in these areas, we call it as hirsutism. So we look at the pathophysiology of PCOS. The most important culprit here is the insulin resistance, actually. Okay, so that's why most of the PCOS women are obese, and even there is an entity called lean PCOS. Even though their BMI is normal, they have increased visceral fat, which predisposes them to insulin resistance. Actually, this is the main culprit, and this has to be targeted. So what happens is when there is increased insulin resistance, this leads to ovulatory dysfunction. So what happens is this triggers the GnRH. This alters the GnRH pulse. Actually, what happens? I told you already, GnRH is the main. There is a pulse regulator there. It sends pulse. So what happens during a cycle? Usually there is a follicular phase, then followed by luteal phase. During follicular phase, the FSH rises, and towards the luteal phase, the FSH comes down. The FSH rise is responsible for recruitment of follicles, and then comes the LH surge, which will select the dominant follicle. Because of the LH, only one follicle will enlarge and become dominant, then the ovulation occurs. Okay, so this LH, FSH and LH coming into play is dependent upon the GnRH pulse activity. So when the GnRH pulsates faster, LH will increase. When the GnRH pulsates slow, the FSH increase. So when there is a problem with the GnRH pulse regulator, what happens? This normal process get altered. So what happens in PCOS is there is persistently this GnRH will keep pulsating faster. The frequency will be higher. So because of that, there is increased LH. So because of the increased LH, the follicle won't that follicular selection won't occur. So they end up having multiple follicles in the ovary. So there are different criteria which have been used, and the most commonly used one is the Rotterdam criteria. But remember, before labeling a person as PCOS, it's very important to rule out the secondary causes, which is common for all. We have to rule out all the secondary causes of PCOS. This is basically when we say PCOS, it's primary PCOS. So the other secondary causes of PCOS, meaning hypothyroidism, other Cushing syndrome, hyperprolactinemia, all these causes has to be ruled out before we label someone as PCOS. And so Rotterdam criteria says that among these three, either two has to be present. That is, I'll go into the details. So clinical hyperandrogenism, biochemical hyperandrogenism, and a polycystic ovaries in the morphology in the ultrasound. So by clinical hyperandrogenism, what we mean is presence of hirsutism or presence of acne or presence of male pattern alopecia, that is frontal recession of hair, that loss of frontal hair in the females. So that is called male pattern alopecia. And by biochemical hyperandrogenism, what we mean is elevated testosterone. So elevated testosterone in a female, anything which is more than 50 nanogram per deciliter, we take it as significant. Okay, but remember, most of the PCOS women will have a level less than 50. That means that maybe their skin is more sensitive to even to a lower testosterone level. So that is why it is not always necessary that they have to have biochemical. The clinical is enough actually, and there should be a history of anovulation or oligomenorrhea, and they should have this polycystic ovary in the ultrasound. There is specific criteria for that. So out of these three, if two is present, we can label them as, we can diagnose them to be PCOS once the secondary causes of PCOS has been ruled out. So now coming to a case, which this is an 18-year-old lady who's unmarried, who has come with irregular complaints for 2 years and has increased facial hair for about 1.5 years. So similarly, we should know what are the causes of hirsutism or androgen excess. That is, menstrual irregularity plus hirsutism means that there is excess androgen. So what is the reason? We should first know the causes before going into the history. So remember, even if I have put a full slide of causes, PCOS remains the major cause. So there is a saying that when someone presents with oligomenorrhea and hirsutism, the first diagnosis is PCOS, second diagnosis is PCOS, and the third diagnosis is PCOS. So very rarely we encounter something other than PCOS. I'll tell you when we have to suspect something other than PCOS. So this hypertrichosis is something which will occur in usually in the women during the 30s, and rarely ovarian tumors and non-classic CA that is congenital adrenal hyperplasia. It's a non-classic form. This is something which can occur in later life. I'll come to tell few points about it. Usually they will have, or all the most of the other causes will have, mostly will have signs of virilization. I'll come to what is virilization. And also, you also ask for drug history. Any history of glucocorticoid intake, some anti-epileptics like phenytoin, all these also can cause hirsutism. So as in any other history elicitation, when we ask, you should ask about the onset, you should ask some associated symptoms, because presence of these symptoms mean that the patient may be having a pelvic inflammatory disease. It may be a local cause actually. And also hirsutism also, in addition to whatever we are asking, it's very important about rate of progression and presence of virilization, because if it is a rapid onset, when we have to suspect something other than PCOS is when there is a rapid onset. Someone comes with a history that less than 6 months history, that suddenly I started having this, suddenly my voice has changed. So that is when we have to think about other causes like presence of some tumors. Okay. So we have to ask for history of. So when we look at the signs of virilization, one is deepening of voice, the other is clitoromegaly, male physique, having a manly appearance, a muscular appearance. So these points towards virilization, and also breast atrophy. Already they had breast development and suddenly the atrophy, the glandular tissues coming down, that again is a sign of virilization. Okay. And acne, male pattern alopecia, these are the general, and these are causes, these are something to rule out secondary cause PCOS. That is because even prolactinoma, hyperprolactinemia, and Cushing's disease can also cause hirsutism and oligomenorrhea. So in an examination, it's very important to look at the weight, because I told most women are often obese. About 80% will have obesity. Only a small proportion will have lean PCOS. Look at the blood pressure. And these days, young onset diabetes is very common. That too, type 2 diabetes is very common. So look at the metabolic parameters as well. And look for features of hypothyroidism, Cushing syndrome, galacturia. This to rule out the secondary causes of PCOS. And very important, when they complain of hirsutism, quantify how much is the hirsutism, quantify the score. Acne, not small acne, the bigger one, especially the pustular ones and the one which comedones, they are considered to be signs of hyperandrogenism. And look for signs of virilization already elicited in history, that when we speak to the patient itself, we can notice any change in voice. And the other thing is breast atrophy, male psych, and clitoromegaly. So this woman had symptoms for 2 years, which is reassuring, not immediate onset. She had irregular cycles, she had facial hair, and very important, she didn't have a progressive thing. She told that it just came, it stayed like that. And there is no history of virilization, and she denied any history which is suggestive of secondary PCOS. Examination as well, other than obesity and signs of insulin resistance, there was nothing significant in the examination as well. So this is very clear-cut case of primary PCOS. So what do we do is we always do very limited investigations, because they are obese. Just check their blood glucose, check their lipid profile, rule out, do a thyroid function test, serum testosterone, and USG pelvis. These are actually not always required. Prolactin is required if they come with an irregular menstrual cycle. If someone comes with only hirsutism, there is no need to do a prolactin. And LH, FSH, especially FSH, if someone comes with, there are people who come with history of 1 year of amenorrhea, 6 months of amenorrhea, then you need to do a FSH, otherwise not required. That LH FSH ratio of 2:1, that is not routinely, we don't do that routinely in clinical practice. And if clinically indicated alone, we will do this. If we are suspecting Cushing's, we do serum cortisol. Most often you will see serum cortisol in our investigation order, because we are not suspecting Cushing's there. Actually, we are just ruling out exogenous use of steroids, because exogenous use of steroids have become so common these days. When someone comes into obesity, just to rule out exogenous steroid use is what we are asking for, that cortisol. And 17-hydroxyprogesterone when we suspect late onset CH. When we suspect late onset CH is that someone is thin, they have oligomenorrhea and hirsutism, which starts early in menarche. And also there's a family history, like consanguinity is there. There is history of some infantile deaths, or sometimes coming with the history that some of the sibling is affected. That is when we have to suspect 17-hydroxyprogesterone. Also, we suspect late onset CH when someone gets referred for failed ART, like artificial reproductive techniques. They are failed for, they are planned for fertility and they have tried it, but the reproductive medicine physician refers to that they are very resistant to treatment. That is when we rule out late onset CH. So approach to hirsutism, very important thing to remember is look for virilizing tumors. When there is a very rapid progression, there is presence of virilizing symptoms and there is high testosterone. By high testosterone, the cutoff which we mentioned is more than 200 nanogram per deciliter. Doesn't mean that everyone will have more than 200, but someone who has a testosterone more than 100, little be careful. It's necessary to rule out tumors. And secondary causes of PCOS, we have to look into, look at the clinical features, look whether they have Cushingoid features, family history, thin phenotype, failed artificial reproductive techniques, rule out late onset CH. And also when they have very high testosterone or DHEAs, you should rule out secondary causes like late onset CH. So treatment, so most important treatment, in addition to all this, whatever we are, our aim is to restore the regular menstrual cycles here and to reduce the unwanted hair growth, what is there. So, and also the most important advice which you have to tell the patient is weight reduction. Okay, that is very important actually, because that is only going to target the main pathogenesis, that is insulin resistance. So, and also we should look for other associated, like some adolescents, when they have PCOS, they come with other associated features like metabolic problems. So we should carefully screen for them and we should sort out them as well. So treatment, the main treatment modality is lifestyle modification. Previously, it was a very usual habit to put anyone who is PCOS on metformin. Now, studies have shown that metformin doesn't help much unless they have pre-diabetes, some associated metabolic conditions, only then metformin will help. Otherwise, we have stopped using metformin for like previously, maybe about 5 years back, anyone has PCOS, metformin will be there in the prescription. Now, no. So OCPs are the first line, because what does OCP do is when we give cyclical progesterone estrogen from outside, this is going to reduce the gonadotropin level. So that is what the major, like because of there is GnRH pulsatility problems, because of that LH level goes high. That is one of the pathogenesis. So that is what we are targeting in OCPs. So if OCPs doesn't work, once we use OCPs and it is not working, even after 6 years or 1 year, you can add on anti-androgen when hirsutism is the main problem. Okay, but remember, not everyone can be treated completely with medical management. So once you have ruled out secondary causes, refer to a dermatologist for cosmetic measures as well, which can go side by side, medical management and the cosmetic measures. And also, if fertility is the main concern, no OCPs, refer to a reproductive medicine physician, because they will do ovulation induction and others. When fertility is the main concern, don't start anyone on OCPs. So there are multiple cosmetic measures like plucking, waxing, and laser has more success. And also remember, laser is also not 100%. With multiple sittings, like 5 to 6 sittings, the efficacy is about 60 to 70%. Okay? So that is why not one measures, we have to target everything together. So now going a little bit about disorder of sexual differentiation. So before going into disorder of sexual differentiation, you should know how does a gonads develop. When a gonad develops, initially to start with, it is an ambipotent gonad. So then depending upon the presence of X chromosome, previously it was very simple. They used to tell that it is based on the presence of Y chromosome or not. Now with the advent, multiple transcription factors come into play. But remember simply that when there is a Y chromosome and this SRY, when it is present, they develop into testes, and the absence of this makes it a ovary. This is a simplified version, but this is not as simple as that actually. So any problem in this pathway or any problem in any of this can lead to disorder of sexual differentiation. So what we mean by disorder of sexual differentiation is there is any alteration either in the chromosome or in the gonad or in the anatomical sex. So someone looks normal phenotypically doesn't mean that they don't have DSD. The ambiguity may be in the gonads which are present inside. The ambiguity may be in the chromosome. Like as I said, Turner and Klinefelter are the chromosomal DSDs actually. Though they don't look ambiguous externally, but they have chromosomal anomalies. So when we work up, so these three terminologies are very important when we look at this. Is you can leave off this. This is occurs in infancy. Gender role, gender identity, and there is something called gender orientation. So gender role is like how does the patient behave. Sometimes it may be a girl. Usually gender role get established as early as 3 years. That may be a girl, but they tell that she always wears shirt. She always plays with cars. She doesn't like doll. So that means that she's taking a gender role of a boy. That's called gender role. And gender identity is how is the patient being identified in the society. Like in class, is she identified as a male or female? In the society, how she is identified? That is what gender identity. And gender orientation is what does the patient feel? If they are attracted to a male, they are females. If they are attracted to a female, they are males. That is called gender orientation. Okay. So these three things are very important because this is important when we decide on the treatment. And it's all about examining the genitalia. I'm not going into the details. I know I can't cover DST just like that because it requires a lot of going through the physiology, explaining you how each things develop. So I'll just show you shortly few cases of DST. Look at three cases of DST which we encountered. So this is a 25-year-old lady who presented with oligomenorrhea and hirsutism since menarche. Her primary concern when she presented was infertility. That is why she was referred to us actually. She was reared as a girl and her gender role, identity, orientation, everything was female. So she had a normal height. She had hirsutism, which was very obvious. She had a modified FG score of 16 out of 36. And she also had on examination, so though she was not very aware, she had clitoromegaly. Okay. So the clitoral, so how do we define clitoromegaly is that if the length of the clitoris is more than, like it's more than length, we should take into account both the length and the width of the clitoris. So if the length into width is more than 35 millimeter square, that is why we called clitoromegaly. This is very subjective. Sometimes a person who is tall can have a little bigger clitoris. So, but she had a very obvious phallus kind of thing, clitoromegaly, and otherwise she was completely female looking in the genitalia. So we did a karyotype which was 46XX and her 17-hydroxyprogesterone level was elevated, which was 15.4, which was suggestive of late onset congenital adrenal hyperplasia. So this is a 16-year-old girl, again reared as girl, who presented to us with primary amenorrhea. So her gender role, identity, orientation was female, but she told that she started having breast enlargement by 12 years. I now have a fully developed breast, but I don't have menses. That is the reason she came to us. So when we looked, she had a height of 161 and the parents were not available to compare their heights. She had an upper segment, lower segment ratio of 0.86. And also looking at the tanner, she had B4, but there was only P2. There was not much of pubic hair development and she had a female phenotype. And then when we did the karyotype, it was 46XY. And when we looked at the abdomen, we couldn't palpate the gonads. When we looked at the MRI pelvis, there were no Mullerian structures actually. Actually, we did the ultrasound first, which shows absent Mullerian structures, and also we couldn't palpate the gonads. That is why we went for an MRI pelvis to look at the gonads, and she had intra-abdominal testes. Okay, this is very important to look at the gonads because these gonads, if they are left in situ, they can have malignant transformation. Okay, so this patient had an elevated LH and a normal FSH and an elevated testosterone. Look at the testosterone; it's normal, but doesn't have any features of no features of virilization. So this is a probable case of complete androgen insensitivity syndrome who has come as a male. Why did she develop breast? Testosterone get converted to estradiol. So that is how she developed, this patient developed breast. However, she didn't have any other features because of the insensitivity. So coming to the third case scenario, this was a 21-year-old reared as boy. He was completely happy as a boy, but one day he noted that he is having cyclical hematuria. So 3 days in a month he will have bleed in the urine. So that is when he came to clinical attention, had a gender role, identity, and orientation as male, born of important history, born of non-consanguineous marriage. There was ambiguity which was noticed at birth, but parents didn't take him to any physician. They thought it is normal. This is a boy. He will become normal when he grows up. So by 15 years, the boy developed bilateral breast enlargement and also underwent mastectomy for the same actually. So here itself, it says that probably this is a girl actually. So he has been reared as a boy, and he looks masculine. He looked normal. It's very difficult to take sometimes clinical photograph of people who come as adults. They are very much concerned about even who examines. They won't even sometimes agree to two people examining. They tell, can you alone examine? I don't want the other person to see. So that's why I don't have clinical photographs. So he was actually shot 146. Another thing is he had a high BP, he had hypertension, and he had a phallus which is 3 centimeter, and the opening was at the base, and there was only one opening. For a female, we expect two openings, right? One urethral opening and vaginal opening, but this person had only a single opening, and there were no gonads which was palpable in the genitalia, and also had a labial fusion, which is not which we won't expect in a male. Okay. So investigation karyotype revealed 46XY. LHFSH were normal. Testosterone was high, 270. Surprisingly, congenital adrenal hyperplasia was in mind. It came normal. Okay, 17-hydroxyprogesterone was normal, but this is a rare form of congenital adrenal hyperplasia, that is 11 beta hydroxylase deficiency. Usually, the 21 alpha is the one which is the most common, which constitute about 95% of the cases. But however, this was 11 beta, which had elevated 21 cortisol level when we evaluated the steroid profile. And because of the, you would have studied in MCQs that which CH is associated with hypertension. So there are 217 alpha and 11 beta. So this was 11 beta. The genetic testing actually confirmed the diagnosis also. Okay. And the USG revealed uterus and ovary with follicles. Thank you. So if anyone has any questions.
Any questions? I think a very difficult topic taken very well. Ramya, I want to thank you. I am sure all of you would want to allow it to sink and digest. And your lunch is available only after you've done the post test, right? So, was it easy, the pre test? Was it difficult? Is it a little clearer after you've gone through the lecture? Do you need some more time to let it sink through? I'm sure something that we don't see that often, but I think thanks Ramya for really taking this topic so well. So, anybody wants to ask any questions?
Have any doubt in the pre-test questions?
Any doubts in the pre-test questions? Now they'll be doing the same one right now. So take your time now. You have your time now. Quickly go through the test. See what you are able to do. If you complete that, then you'll be allowed your lunch, and then you can run for your work. And we'll be the lunch inside.